On behalf of BLK Center for Child Health and IAP Central Delhi branch, I welcome you all to this BLK Telepedes webinar. Epilepsy, as we all know, if untreated, can cause long-term neurological damage, and when it is not associated with clinically evident seizures, it becomes even more difficult to recognize and treat them. So how not to miss such events, that we will learn today. And to chair the session, we have experts with us, Dr. Colonel Rekha Mittal. Welcome, ma'am. She is Additional Director, Pediatric Neurology at Madhukar Rainbow Children's Hospital, New Delhi. And she is the founder member of Association of Child Neurology, as well as she has been the past president. Ma'am has served in Army for over 10 years and subsequently several hospitals in New Delhi. And her areas of special interest are epilepsy, cerebral palsy, and developmental delay. Welcome, ma'am.
Thank you.
And with us, we have Dr. Prashant Johri. He is Additional Professor, Child Neurology, Division of Child Neurology at Department of Pediatrics, All India Institute of Medical Sciences. He has authored several publications and chapters in Index Journal, and he is also the faculty for DM Pediatric Neurology program. His main area of interest are neuroimmunology, TMS in refractory pediatric epilepsy and movement disorders, as well as CNS tuberculosis. Welcome, Dr. Prashant. I would now request our chairpersons to kindly introduce the speaker and start the session.
Dr. Rajni, may we have your first slide, your introductory slide? I mean, your CV slide?
I haven't put up my CV slide, ma'am. I'll just check it.
Okay. Anyway, so good afternoon, everybody. Today is a very interesting talk by Dr. Rajni Farmania.
Is it visible, ma'am?
Yeah, it's visible. She has done her MD from Jaipur and DM from Pediatric Neurology in AIMS, as you can see on her slide. And she's currently in Max BLK. But this is the place of work, but she's an excellent speaker, very lucid, very clear. And she has chosen a topic which is fascinating because we are all familiar with, epilepsy, having seizures. Now, she will tell us a completely new aspect, epilepsy without seizures. And I'm sure it will be very interesting and an eye-opener. So, Dr. Johri, do you have something to add to that?
No, ma'am, thank you. I would just like to say that indeed you have already said that Dr. Rajni did her DM at AIMS New Delhi, and since then she has been a very decent colleague, very well respected in the field of pediatric neurology in New Delhi. And I am open to her to listen to her talk, and let us see what she would like to tell us about this topic.
Can someone put off that ping sound that comes when someone joins? Because it's a little distracting.
Yeah, I'll do that now.
Okay. So good afternoon, everyone. Shall I start, ma'am?
Yeah, please go ahead.
So I welcome you all on the behalf of BLK-Max Hospital and to the webinar, monthly webinar. This topic is very special, and I have chosen the special title also, that epilepsy in children without seizures. By convention, we all know that epilepsy is 2 episodes of seizures without any unprovoked factor and 24 hours apart. But medicine is an enigma, and it actually fascinates us that there is atypicality is a rule, though very rare, but atypicality is a rule. Today in this session, we'll go through the case-based sessions where there are atypicalities and where we do not classify the events as typical seizures, but still we all should have a high index of suspicion, and with clear evaluation, we will be able to make them as a diagnosis of epilepsy and do the appropriate management. So as we all know, the practical definition of epilepsy. The voice is still on, Dr. Swati. The background noise. I think joining noise is on. Hello. Am I audible? Shall I continue?
Yes, we can hear you, but that ping thing is still coming.
Okay.
Anyway, please carry on.
Yes, ma'am. So we all know the practical definition of epilepsy, that it should be two convulsions which are unprovoked and 24 hours apart, or if it is one typical seizure which has a high risk of recurrence. And the third one is if the child has a typical epilepsy syndrome, if that particular case. So we have certain cases which do not fall typically into this category, but yes, with our further evaluation, we will be able to fix into these categories and then make the diagnosis. This is just a typical diagram which Eyelid has given us, that when we approach a case towards any abnormal movement or seizures or supposed seizures, then we should be able to try to classify into focal onset or generalized onset, or if it is unknown, it is unknown onset. And then there is a classification of different etiologies. What is on the basis of history, which are the different etiologies you are able to fix, and then what are the epilepsy types, and if you are able to fix into epilepsy syndrome, then what are the epilepsy syndromes. And the management will be depending upon the comorbidities. So this is a basic diagram. When we deal a case of epilepsy or a seizure, we go ahead with this. So let's get into the cases. And here I would request to the participants that we have certain questions in each case. If you have some answers or some clues, please write in the chat box. And it will be interesting to have a two-way interaction. If we have no answers in the chat box, then we'll go ahead with the answers. So first is a 5-year-old girl. She had 2 episodes of vomiting in sleep at a 6 months interval. So child gets up in the middle of the night. She complains of nausea. She has vomits during the episode, but she stays conscious. She has some fear, some confusion, but she is responding to the commands during those episodes, and she sleeps back again. The duration was somewhere around 15 to 20 minutes. And during the first episode, the parent were just considering this episode as a food poisoning or related to some kind of abnormal GI upset. In the second episode, they got a little worried that why the child had this kind of abnormal fear or confusion episode. So what is the differential in this case? What do we consider? Is it just a food poisoning, or can it be related to any seizure or any abnormal episode, any neurological episode? There was no abnormal eye movement, no focal staring, no abnormal stiffness of the body, so as to say as a typical seizure episode. Does anybody has any clue? If we have residents in the group, please put your answers in the chat box. So in this case, since with this episode, we thought that the child had vomiting, some abnormal fear and conscious episode. Obviously, the treating pediatrician, they went ahead with the GI workup first. They went ahead with the blood check, LFTs, ultrasounds, and everything came out to be normal. Child, in fact, did not have any further recurrent episodes in those next 2 to 3 days. But then when the child was not, we were not getting any evaluation, the child was referred to a neurologist. They had done an EEG routine also, but still to provoke further on this case, they sent to a neurologist. And here, when the child came to me, what would be the other diagnosis? I mean, I would just ask the house that what can be the other differential diagnosis and what should be the next plan. So yeah, somebody has written in the chat box. So rightly, yes. So I also thought that the child has a Paediatric syndrome, and then I advise the child as a sleep deprived EEG. So now here I would say that the child had the event in sleep. So here comes the importance of putting the right investigation. Though our colleague had written a right investigation EEG, but it should be with the right protocol. It should be in a sleep deprived mode. Sleep deprived EEG doesn't just really meaning that we give a sedation and we get a sleep record. We want a awake record, we want a drowsy record, and the best is to get a natural sleep record so that you see the waves how it is changing. So in this case, we went ahead with a sleep deprivation EEG. So here initially what we can see is a awake record. Here as such overall looks nice. This is hyperventilation record. Next we went ahead, we got one suspicious spike wave discharge in the occipital region and little spike wave discharges here, 3 to 4 hertz. But to unexperienced eye, this might look normal. But as the child went into drowsy feet, we could see that increase in the occipital discharges from the O2, that is right occipital region. And even during the photic stimulation, this is a photic stimulation, we saw that there is some potentiation in those discharges. We went ahead with the sleep record. You can see some spindles here, and here it is 3 to 4 hertz, typical spike wave discharges in the sleep record. So yes, in this case, when awake EEG record was done, it was reported as totally normal. And when we did this EEG, this is a total game changer, and it could make a correct diagnosis that the child had a Paediatric syndrome. The recent nomenclature is self-limiting epilepsy with autonomic symptoms. So this is a very underdiagnosed, benign, age-related focal epilepsy disorder. So once you have seen or experienced one case, you'll never forget it. And the onset is very classical, 3 to 6 years of age. And in 3 to 6 years, it is around 13%. They present with afebrile seizures in a nocturnal state. So 2/3 of the seizures are in the daytime seizures or in the nocturnal state. The duration is very variable. So here, like a typical GTC seizures, which stays for 1 to 2 minutes, or in the case of status, a prolonged event, these events, they tend to be prolonged. In more than 50% of the cases, these are more than 15 to 20 minutes. So that is why some of the cases, this is the same age as a case of sleep terrors. So in some cases, they are misdiagnosed as sleep terrors. They may be misdiagnosed as some cases of food poisoning or some other cases, till the time they have a clear typical seizure episode during that event. So it is very common to miss these initial cases. The development is usually normal. The etiology is presumed to be genetic, and mostly there is no family history. But yeah, in some cases, the child might have had a febrile seizure or a sibling who had a febrile seizure or a benign Rolandic seizure. So autonomic seizures are the hallmark. In 80 to 90% of the cases, the nausea, the vomiting, basically, if we take the clear history, so here comes the importance of taking a clear history that what actually happened. The retching, the nausea was very characteristic, and in 80% of the cases, we will be able to get in these cases pallor, incontinence of urine, or fecus, or hyperventilation, or hypersalivation is around 10 to 50% of the cases. Syncope-like manifestation. Basically, they say that the child just had loss of consciousness. The child woke up, had vomiting, loss of consciousness in around 20% of the cases. So they can become unresponsive and flaccid like a rag doll, not having a typical seizure phenomena. So ictal behavioral changes are more marked than compared to the GTCS or eye movement or a posturing kind of thing. And pure autonomic status is also seen in 10% of the cases. So that is why the nomenclature is self-limited epilepsy with autonomic seizures. So SELAS. So this is a recent classification and a very common phenomena we see in our OPD 3 to 6 years of age. So here we have a mandate criteria: focal autonomic seizures with or without impaired awareness. So here, even without awareness, without impaired awareness, we can make this diagnosis. EEG is classical, which is specifically seen in drowsiness. It increases in drowsiness and sleep state, and MRI is mostly normal. Neurocognitively, they are absolutely well. So exclusionary criteria is neurocognitive regression. So if the child is well, the development is well, there is no regression, and it has a good prognosis in the terms of remission by early to mid-adolescence. So prognosis-wise, it is good, as I said, that they might evolve. Some of these cases might evolve to other benign Rolandic epilepsy, other self-limiting epilepsy, or they might be absolutely well. So case 2, a 10-year-old girl, she had two paroxysmal episode of abnormal visual phenomena. So during the first episode, she had a headache and she had colored halos. That was at the start of the event of that headache. After the headache, the visual phenomena also went off and the child was well. After 6 months, she had another episode during which she had paroxysmal, again, loss of vision. So this time the vision was prominent. For 15 minutes, she could not localize or see that where the objects were or where the parents were. She stayed conscious during the episode and she had a little nausea and vomiting during the episode. Both the episodes, she had no loss of consciousness and there was no eye deviation or any motor phenomena. But the visual phenomena was predominant along with headache. So here, what is a provisional diagnosis and what should be the next investigation? So do we have anything in the chat box? Here, does the house or any residents, they feel anything in this case, that anything to be worried on the neuro side? So yes, first diagnosis was thought to be migraine. So rightly, obviously it should be ruled out. So first diagnosis, what is a provisional diagnosis? What should be the next investigation? Should be advised. Basically, in this case, it was diagnosed as migraine with visual symptoms, visual aura, and flunarizine was started. Now, the same case, she had another 2 episodes even after starting the treatment of migraine. So in one such episode, she had persistent gaze to one side and she had unresponsiveness. And then it was classically looking like a neuro case or a neurological case in terms of epilepsy. And during this time, she was evaluated further. MRI brain was normal, and then we did a sleep deprived EEG. So the ideal investigation during that time, as I asked in the first slide, was a EEG should have been done to rule out epilepsy, because another question for EEG, if we have some residents, that what is the special activation phenomena we do during EEG? What special instruction would you like to give to the EEG center to be done in these cases? One is sleep deprivation and the other one is fixation of sensitivity. So yeah, this is a very special kind of epilepsy in which we see a special phenomena which is called fixation of sensitivity. So this is the EEG record of that child, awake EEG record. Here we can see the temporo-occipital spike wave discharges. Basically from the posterior head region, you can see some spike wave discharges which are running when the eyes are closed. So eyes are closed here. And when we put the eye open, if the child has eyes open, there will be no spike wave discharges. So this is called fixation of sensitivity. When you fix your eyes to an object or in a particular place, there is no spike wave discharges. Occasional, just here I can see a very little one, but there is no spike wave discharges, which is classically different from when you keep your eyes closed. Another phenomena is sleep deprivation. So here, when the eyes are open, it is very less. And when the child goes into sleep, it is even more than the awake state. That is called, there is sleep potentiation or increase in the sleep discharges, where we can see increase in the frequency as well as amplitude in the discharges. So this is classical idiopathic childhood occipital epilepsy of Gestalt, or the recent classification is childhood onset visual epilepsy. So this is the spectrum of occipital lobe epilepsy in the early childhood. As I showed in the first case, 3 to 6 years of age, that is Paediatric syndrome. And the same as the child goes older, the same occipital lobe epilepsy can have a different symptoms. They can have headache, they have visual phenomena more predominant than the earlier one. In the earlier one, vomiting was a particular phenomena. So this is little less than the early ones, that is 2 to 7%. And in a child whom we suspect as migraine with visual phenomena, an EEG should definitely be done to rule out this kind of epilepsy, because they have elementary visual hallucinations, which is often the first symptom and not before the typical seizure symptoms appear. They can have ictal blindness, which is second common. Complex visual hallucinations can also be seen. And headache is very common. You will definitely get a history that even before these symptoms or after this symptom, they can have headache. So a very common differential for migraine. So this is case 3. In case 3, this is a 14-year-old boy. He had abnormal movement with preserved awareness and these kind of movements while he's writing. He's all aware during this time. And in the second time while he's eating. So there was no time restriction that in the morning or in the evening, but we could see that the child had these abnormal movements. So any idea on this, that what are these movements? And should we really consider this to be neurological or anything else? So what are these movements called? These are myoclonus. So the child had only the myoclonus, child was absolutely well, no other. So what history should be leadingly asked in these cases? When we get an adolescent boy or a girl with these kind of complaints, The other history we should ask is any history of absences. That is, does the child have any ocular phenomena, or the child ever had any other past episode of seizure? So this is a very special kind of epilepsy which we see in adolescents. We suspected a case to be having a juvenile myoclonic epilepsy, where these myoclonus, they can be the precursor, the absence seizure, which are very rare, clinically very rare in 10 to 20% of the cases. But even before GTCS, the children can have this. Okay, so when we did the EEG, we could see that the child had generalized spike wave discharges. Here it is photic stimulation. We could see 4 to 6 hertz typical spike wave discharges. Yes, during photic stimulation, and we made the diagnosis of juvenile myoclonic epilepsy. So we can see that the child had abnormal movement, no GTCS, but we could even stop during that time. Child is still in follow-up 3 years from treatment now, no further event, and he is well maintained on single drug of sodium valproate. So this is another very interesting case. Here I put voice purposefully on for all of us to just learn from this. For these cases, I would request that nobody should make a video. These are just learning cases. And here we would see that. So this is, she is a 5-year-old girl. She had these paroxysmal episode where the mom is speaking.
हाँ क्या क्या नहीं
So mama is asking, but child has some
क्या हो रहा है
abnormal
बच्चा?
retching or nausea kind of thing. She's upset.
हाँ क्या हुआ?
So she looks a little upset and
नायरा क्या हुआ?
not responding appropriately. Okay, so these episodes, so this initial movement, if
क्या हो
somebody
रहा है
can
नायरा?
write in the chat box, what is this? She had some, this kind of thing. If somebody can write, it will be very, I mean, it's good if somebody can recognize what is happening. So this is a second video.
क्या हुआ
Again,
हैंड्स में?
she is doing some kind of mannerism. Yes, she's doing
हाँ,
some
गा
kind
रही
of
हूँ।
mannerism.
हाँ जी बोलो।
She's awake, but she is doing some mannerism.
क्या समझ नहीं आया? क्या बोल रही थी? कौन कब
Speaking
आओगे?
irrelevantly. Basically,
अच्छा मैं कौन बैठी हूँ सामने आपके? मैं कौन हूँ?
so speaking irrelevantly. You can see the same thing in the third
क्या हुआ?
episode.
हाँ मम्मा आ गई। पापा तो घर पे नहीं है।
So again, she's speaking. Mama asked Papa. So confusional episode. So here, does anybody has idea? Is this epileptic phenomena or a psychogenic event? Or what are these events?
क्या हुआ? क्या हुआ हैंड्स में?
So is it seizure? And what is the semiology like? So anxiety, somebody has written anxiety. Lip smacking is right. So yeah, so initially it was thought to be a psychogenic event, and she was not paid typical importance till the time it kept on increasing, multiple episodes in a day, and then we had evaluated the child further. So just to evaluate this case, first let's go back to the basics, whether it is focal onset or generalized onset or unknown onset. So in this video, the lip smacking phenomena, what we are able to see is a automatism. So definitely this is an epileptic episode. This is not a psychogenic episode. In each of this video, we could see some abnormal automatism. Sometimes she was doing some hand phenomena, sometimes oral lip smacking. So automatisms is sure. So it is focal onset with impaired awareness because she had abnormal confusional episode. She was not totally aware. She did not have the insight of what it is happening. So it is focal onset, impaired awareness. She had automatisms and she had cognitive features. So then it comes to the onset of focal onset. Now you know it is focal onset seizures with preserved awareness. Sorry, this is impaired awareness and non-motor onset and cognitive. So a very basic cartoon which shows that when we look into the history of epilepsy or any abnormal event or any paroxysmal event, we try to fit into one of these lobar symptoms. So in this case particularly, I pointed towards a temporal lobe etiology because the child had an aura of olfactory or psychic phenomena. She did not have typical seizure yet, but if left untreated, she will definitely have a long convulsion episode. She just had automatisms, she had loss of awareness, and no aura was identified in this case. But compared to other episodes in occipital, as we had seen earlier, they had colorful but visual changes. They can have loss of vision. For parietal, there can be sensory phenomena. For frontal, there are hypermotor seizures is the key word. In insula, it can be pharyngeal aura, paresthesia, oral motor, or autonomic changes. So here we fixed the case to be having a temporal lobe semiology. And then we went ahead with the MRI. In MRI, this is a T2, this is a coronal image, T2 sequence where we can see some bulky appearance of the left side of the temporal lobe, medial temporal lobe. And here in not a very great picture, in T2 flare image, we can see some hyperintensity. So she had some SOL, which we were not able to identify. We advised epilepsy surgery, but then the child was not keen in epilepsy surgery, but she was well controlled on oxcarbazepine and clobazam. So till last follow-up, she is still on medication. She doesn't want any epilepsy surgery workup right away. So this is case 5. Again, a very interesting case. A 9-year-old boy, he presented with difficulty to balance, and he had these kind of a very subtle jerk. So keep all your eyes on the video. Does somebody has any clue to this? He had no loss of cognition. He just had these kind of jerks, which were progressively increasing. Even initially, it was just when he was walking and he had frequent falls. But here, while he is sitting quite alert, he has these kind of movements. What are these movements? What are these jerks or movements? So these are, yes, slow myoclonus. Okay, so this is negative myoclonus or so slow myoclonus. What is the most common differential in our country when we have these kind of jerks in a child? What should be ruled out in these cases? So yes, we have a learned audience with us, and she has pointed it out that at least we should rule out SSP because the child had myoclonic seizure. These are looking like abnormal movement, but these are actually epileptic myoclonic jerk. And when we did an EEG, the probable diagnosis is SSP. We did an EEG, we saw the time locked. So these are slow spike wave discharges, which we could see along with the movement. So awake video EEG is a diagnosis of choice, and we can see the periodic complexes, periodic spike wave complexes, which is called as generalized periodic epileptiform discharges in a progressive myoclonic epilepsy. So in acquired case, first thing should be SSP should be ruled out, and then there are various genetic causes also. So in this case, we fix the diagnosis as SSP. So this is another case. The child is a 3-year-old boy. He had these kind of abnormal movement sunlight. So only during when he is out in the sunlight, the mother said that he is awake, he is able to tell everything, but he had this eyelid movements. So what are these eyelid movements? Again, so some kind of abnormal movement in the eyes. So eyelid jerky movement, these are myoclonia. Okay, so he had some neck myoclonus also. He's getting little restless. So in the sunlight, he had eyelid myoclonia. So this is a very special kind of absence epilepsy syndrome, where when we did an EEG, we got that there is an eye closure sensitivity. Whenever there is eye closure, you'll get burst of discharges. So polyspike wave in the temporo-occipital region with eye closure, that is eyelid myoclonia, and there is a followed by generalized spike wave discharges typical of absence epilepsy. So this is Juvenile syndrome or epilepsy with eyelid myoclonia. So again, a very interesting case. If you don't do a awake EEG, you do not do eye closure, you do not pick up that eye closure sensitivity, it is difficult to make a diagnosis of this case. So this is case 7, and he's a 4-year-old boy. He had autistic regressions noted since the age of 2.5 years. This is a very common history that most of the parents with children of autism, they say that the child was well till 2.5 years, and then the child actually lost all the milestones, did not speak anything. So even in the true cases of autism, we get these kind of history. He had one febrile convulsion at the age of 2 years. That was the only significant history. He was diagnosed as autism spectrum disorder. But when we as a pediatric neurologist or as a developmental pediatrician, if somebody tries to evaluate this case, what investigation should be done to rule out any autism mimic in this case? Is an EEG. Okay, so we should do an EEG. In EEG, definitely in a sleep stage. So here again, the importance is sleep deprived EEG and getting a EEG in a sleep stage, because awake EEG can again be normal. So very important, especially in pediatric neurology, that sleep deprived EEG makes a hell lot of differences, as we had seen in past cases also. This is awake EEG of the child. And here we see that the two initial pages were just awake EEGs, normal posterior dominant rhythm. As the child goes into sleep, we can see generalized burst of discharges, which are very frequent, getting abandoned. As the child goes into sleep, they are abandoned discharges, and the EEG is full of that. So this is CSWS, as we were speaking in the older concept, and the newer term is DEE-SWAS, that is activation in sleep state. So there's activation or potentiation in the sleep stage, nearly continuous, and mostly in the non-REM sleep, the threshold can be 25 to 85%. So there can be epilepsy, there can be neuropsychological regression, and there can be electrical status epilepticus in sleep. So this is a typical case of autism mimic, where if we have a child who is suspected to be autism, has some regression and seizures, definitely we should go for an sleep EEG to pick up these cases, because the treatment line is definitely very different than the typical autism spectrum disorder. So this is the last case. Is a 9-month-old child who had skin lesions, which are typical of a tuberous sclerosis. The child's echo was done, which was showing cardiac rhabdomyoma. MRI brain showed subependymal nodules, and diagnosis of tuberous sclerosis was made. Now, since we know that the 80 to 90% of the children can have some neurological features in terms of epilepsy or intelligence, epilepsy plus or minus intelligence issues, the child neurologically till this state was normal and had no convulsions. So can we label this child to have definitely epilepsy in the future, or what is the stand right of now? So should we just follow the child for the onset of seizures, or do we do something by doing a preventive EEG? So there is a lot of studies had been done on this, to whether how can we decrease the morbidity in these children from epilepsy, because once the epilepsy starts, it can be refractory in 60 to 70% of the cases. So this was a study, EpiStop trial. Here in this, 94 children were taken, 94 infants, multiple site studies, and somewhere it's an RCT. Open label trial was also taken at 4 sites, and at 2 sites it was RCT. So here, out of 54 subjects, after excluding, it was only 54 subjects, and they could know that the time to start the first clinical seizure was significantly longer than the preventive. Basically, when they followed the children with repeated EEG activities, they saw that the EEG showed the markers prior to the clinical onset of convulsions. So at 24 months, when they did the pooled analysis, they saw that if we do a preventive treatment in these children, they reduce the risk of clinical convulsions, seizures, drug-resistant epilepsy, and infantile spasms also. And there was no adverse event if we do a preventive treatment. So hence, further studies has been done, and we all now do a preventive EEG and start anti-seizure medications if EEG shows some abnormality. So again, the children in these cases, they do not have any seizure, no epilepsy, but yet we start on anti-seizure medications. So the carry home message is, A high index of suspicion must be kept for any paroxysmal episode. The definition of seizure is any paroxysmal episode which has a neuro onset, basically abnormal electrical activity of the brain, which leads to the paroxysmal episode. Sudden onset, sudden offset for a short time should be considered to be of neuro origin rather than cardio origin, I would say. So preferably, they should be at least considered as a differential for neuro origin. A good quality technical and a reporting of an MRI and a good quality EEG, basically awake EEG or a routine EEG, writing the right protocol that in case of occipital lobe epilepsy, you want a fixation of sensitivity, you want a sleep deprivation EEG in these particular cases. So advising the right protocol and getting a good reporting from EEG makes a difference in these cases. So syndromic diagnosis is again a very special to pediatric neurology that we should always try to make a syndromic diagnosis to channelize the treatment, and that also helps us in prognosis. So all children with autism spectrum disorder who have had a history of seizures or have neuroregression should undergo a EEG in which sleep and awake state both ideally should be tried to be obtained. And anti-seizure medications can be started in cases of tuberous sclerosis where we do not have seizures, but EEG shows abnormalities. So thank you.
Thank you, Dr. Rajni, for such an excellent presentation. And now we can have some discussion. I request the chairpersons also to join the discussion.
Thank you, Dr. Rajni. That was a excellent talk and very interesting cases. And I have to point out here that your case number 4, where the child was just behaving abnormally and so had some irrelevant talk and all, these are the ones that are most often thought of as some paranormal phenomenon. And they often get treated like, bhoot utar do, and things like that. So whenever a child is brought paroxysmal, some behavior changes are there, and they say ki iska, so one must maintain a high index of suspicion for that these could be seizures. And especially in villages and all, these children often get treated, in a very bad way or very unscientific manner. So
till the time they get a proper convulsion.
Yeah, till they get a proper convulsion.
Come to medical.
Suppose it gets generalized, then they will believe that this is actually epilepsy. Otherwise, they keep thinking that it's some paranormal activity.
True. So the moment the pediatrician sent me the video, I saw that automatisms and all. I told sir, please send the child to me. I'll evaluate and go back and see what it is. Because he initially, the pediatric colleague was considering, I don't know whether to send to you or not. Should I send to psychologist? I told sir first send to me, then I will send to psychologist if required.
So there are some questions in the chat box. Dr. Himanshu is asking, what are the absolute indications for sleep-deprived EEG?
Okay. So for sleep-deprived EEG, first should be if a child has any paroxysmal event in sleep. First, I would say that whether it is occipital lobe epilepsy or not, if you have any event in sleep, should get a sleep EEG. For especially these self-limited epilepsy syndromes, like in occipital lobe epilepsy or benign neurologic epilepsy, awake EEG can be absolutely normal. So I would say in clinical practice specifically, the seizures which has a self-limiting phenomena. So mostly they have in sleep only, the sleep-deprived EEG. And even in focal seizures, suppose a child of NCC has a focal seizure. When we get a sleep-deprived EEG, we get accentuation of the focal discharges. So a self-limited benign epilepsy, in autism especially, when we want to rule out CSWS, a sleep-deprived EEG is mandate. And any abnormal event, if you are suspecting in a sleep, should get a sleep-deprived EEG.
I think for those children, most children who are cooperative, we should always try to get an awake EEG as well as a sleep, irrespective of whatever the presentation is. The correct protocol should be that at least whether it is sleep deprived or not, at least we should try to get a sleep EEG as far as possible. Because so many things are picked up during sleep which are not seen in the awake EEG.
Yes.
Prashant, we cannot hear you.
You have pointed out the right thing, ma'am. The question is not about sleep deprived. The question is whether or not you get a sleep or an awake EEG. As Dr. Rekha and Dr. Rajni has pointed out, that sleep gives you a lot of information, especially in the younger age. But at the same time, the awake phase is also equally important, especially in the later childhood when we are thinking of primary generalized epilepsies like absence and variants. So you have to make an informed decision, and wherever feasible, please get a sleep and an awake EEG. So sometimes what Rajni wanted to say is that if you keep the kid as sleep deprived, then the yield of that awake EEG as well as the sleep EEG is going to increase. You will can make the child go to sleep easily, and by the time that arousal or the awake phase that you are capturing, that gives you the chance of picking up these abnormalities. So Rajni, I would also want to congratulate you that you have a good collection of cases, and you have beautifully presented that even if you don't have a motor convulsion, you can still have epilepsy. So that was very good about
Yeah,
it.
that was an important message to get across. So, Dr. Rajni, would you recommend an EEG should be done in all cases of ASD who have a certain amount of regression? Because very often parents do come and so it's a very common thing that parents feel that the child is developing normally till say 1.5 to 2 years of age, and then they say that he's lost some words, or there is an apparent regression, which I think is sort of loss of very repetitive words and all that. Do you think an EEG should be done in all cases of autism? Or which they show some regression? Of course, if there's a seizure, we would do it. But what message should we give to the pediatricians who are dealing with autism? That should
we are sure on true regression. If they produce some videos where we can really see that the child had meaningful pointing, like in this particular case, the child had meaningful pointing, was appropriately speaking, and then he lost. So in these cases, we should get. And in some children, parents feel that they were speaking. Then we definitely ask for some videos. They were just babbling. They did not had meaningful eye contact even during that time. So then we counsel the family that this was initially during that phase also, but yeah, it is more evident at 1.5 to 2 years. So I would then go towards the genuinity of regression. If we feel it is a true regression, we should get it done.
Are there any more questions?
Yes, ma'am. Dr. Vishal is asked, what is the incidence of subclinical electroencephalographic abnormalities in children with ASD, and do we need to treat them?
Okay, so it's a very controversial question. I would say that in autistic children, we can many children, in fact, 20 to 25% of cases may have some subclinical electrographic abnormalities. So main confusion comes here that you have done an EEG, but you get some abnormalities where it is not correlating clinically. Child never had any convulsion, but the child had some occipital or some temporal abnormalities. So what to do in these cases? So in these cases, the guidelines are not very fixed, but yeah, in clinical practice, most of us do not start any anti-seizure medications if it is not significant, I would say. So if it is not, if the child never had any seizures and you have EEG abnormalities, you can follow with 2 or 3 EEGs at a repeated interval to see if it is increasing or the child had some kind of regression. If it is not, then we just pass on this EEG abnormalities as subclinical. Do not start any anti-seizure medications.
Yes, I
So
think,
I think sir can point
right.
on this.
So the crux is that maybe we all can say that all children with autism doesn't require.
Yes, you're right.
We can, as a general statement for all practicing pediatricians, developmental pediatrician and all, we should not be doing EEG, because then it gives you some information which will actually confuse you more. So then it also depends that the quality of EEG reporting also sometimes. So it is one investigation which is abused more, So in scenarios, what Rajni has clearly pointed, that if you have a true regression, so as she has already said, no.
Voice is lost, sir.
Okay.
Now we are able to hear.
Muted me. Okay. So once you have language regression primarily, which is there in autism, which is generally at 1.5, 2 years of age, then that is not a reason to do any EEG. But if you have a global regression with significant aggression, hyperactivity, and other features, which is otherwise unexplained, then you think, okay, you may get a sleep recurrency. So
You're right, sir. Many a times when you do a repeat EEG in our setting with the proper protocol and in a good reporting, I would say, then most of the time we do not find any abnormalities in those cases.
Absolutely.
true, and some bit of abnormality up to even a 50% may have some
Yes.
occasional
If there
spike
is
here
no
and there.
seizure,
They have
no
some, yes.
depression, we do
So
not.
if
some
the person reporting the EEG is not so well versed with this, then he might report it as abnormal, and then you will end up getting confused. So if there is an issue, then maybe a proper referral needs to be taken. So one thing was there, Rajni, that maybe sometimes that tuberous sclerosis issue, that while you have EEG abnormality and you start vigabatrin. So there are issues. There's one school of thought that you have presented, but sometimes, if you lose your drug, which is the key drug, and we know that some visual impairment is going to be there, and generally you don't give it for a very long period. So once it is actually required, you have already lost that weapon. So that is also a school of thought, but it is definitely people are moving towards a preventive care, but it still needs more data, I think, to be.
So it hasn't come as a guideline because there were recent trials which said that.
But this is something important that all of us should be aware of. Yes, this also can be a thought.
Additionally, people are talking of saying that, like, we give vigabatrin for 6 months and then tend to taper off. But the people who are working in tuberous sclerosis, they say that, you should actually continue it for much longer and not to be scared of visual toxicity. So these are all controversies. These are all controversies and require much deeper thought than is, applicable to this session, I think.
So one more question. Dr. Sumit has asked, when to suspect abdominal epilepsy, how to evaluate and how to treat?
So abdominal epilepsy, it's again a very gray zone, I would say, with a gastroenterologist and a pediatric neurologist. So the typical criteria which has been led that if you have some autonomic symptoms along with that, there is abdominal pain, there is something which is paroxysmal. First thing in any case of seizure or epilepsy is sudden onset. So there's a sudden onset, there's a sudden relief. Along with that, mostly if they have some autonomic phenomena in the favor of pallor or some hands getting cold and clammy. So some autonomic phenomena along with that. And then you rule out other abdominal causes. Obviously, you will definitely rule out all the organic causes, and then you do an EEG. If EEG is abnormal, definitely you'll be able to treat it. If EEG is still normal, you can give a trial of anti-seizure medication, considering it provisionally to be an abdominal epilepsy. So sudden onset and autonomic phenomena, I would say, and exclusion of other diagnoses.
And sometimes abdominal migraine may also be confused. So these are all very gray areas.
Gray areas, because EEG might not be able to give us so much of yield.
Yeah, absolutely.
My take is generally is that don't jump to a diagnosis at the first go itself. If there is a confusion, then believe everyone will be confused. So give yourself and the patient time. Maybe if you have recurrent episodes that are typically of the same nature, then you start thinking that there is something more than a GI cause. And both in this.
Usually by the time the patient comes to the neurologist, he's had upper GI endoscopy, lower GI endoscopy, He's been through everything, and when nothing works, then the child is sent to.
But in that scenario, I think what Rajni has pointed out, that if you have beyond your abdominal pain, there's some autonomic phenomena, some subtle behavioral arrest happening along with that. That is what maybe
And
we
it's
can give
very
as a
rare.
message.
From
That
so
if you
many
have
years of
something of this
practice, very rare. I've just made
Very-
one patient I could make a diagnosis of abdominal epilepsy till now. I'm not treating any abdominal epilepsies. Very rare.
Dr. Vivek Arya has made a comment that treat the patient and not the EEG is a famous lesson.
Yes.
I think all would agree with that.
Mm.
We don't have any more questions in the chat
Yeah,
box.
so I think we can end the session here. Dr. Prashant, you have some final what to say, gyan to give?
Ma'am, when you are there, so everyone is looking to you, ma'am. So already we have discussed, I think, important and simple things has already come out, that if you have a suspicion, a paroxysms of event happening in a similar way repeatedly, you may think of, is there something neurological involved or not? And if you are doing an EEG, you have to have a reason for that. Unless and until there is a clear-cut reason, please don't go ahead with with this investigation. And yes, you don't treat EEG, but sometimes it helps you to identify the diagnosis here and helps you to plan your treatment. So as on all these cases where things were not clear on the clinical scenario, the EEG did help the neurologist to come up to a final diagnosis. That is all from my side, ma'am.
Yeah, thank you so much.
Thank you, Dr. Rajni.
Thank you, ma'am.
And
Yeah, so we have come towards the end of the session. First of all, I would like to thank our chairpersons for sparing their valuable time and sharing their experience and expertise with us and making the discussion so interesting and answering all the questions. And as always, thank you, Dr. Rajni, for such an excellent presentation, for making such a difficult topic look so interesting by including relevant videos. I'm sure the audience would be wiser and would definitely pick up, would be help in their practice. And last but not the least, I thank all the participants to be interactive during the session. The recording of this session would be available soon on blkpediatricpractice.com. So those who would like to go back or those who have missed should definitely watch this session. It would be very helpful. And next month again, we would bring you another interesting topic from BLK Telepeats. Till then, thank you very much and a good afternoon.
Thank you.
Thank you.